Welcome, everybody, to a special edition of Driving the Deal. I'm Brian Fortune, head of the Farragut Square Group and part of McDermott, Will, and Emery. As you may notice, this time we're doing a video cast as part of a very fun series that we've put together. So it gives me great pleasure to introduce my special guest today. One of my colleagues, Devin Stone, the head of our wonderful data analytics team. So what we're doing right now is we're going to do a multi-part series, probably one a quarter, and we're going to start breaking down a lot of our own data and healthcare spending and sort of highlight some interesting trends and add our own thoughts on what we think about it on our end. So thank you, Devin. It's really exciting to have you along. Also with us, sitting out there, if you hear chime in, is Ali Vasquez, our longtime producer. So let's dig in. Let's kind of start at a macro level for everybody. I just kind of wanted to walk through, where are we with total healthcare spending, in terms of dollars, and then let's look at it as a percentage of GDP with an eye towards kind of, CMS obviously put out their big expenditure projection report not too long ago, and they have some very interesting thoughts about where healthcare spending is going. So let's dive into that.
Yeah, thank you, Brian. Pleasure to be here and happy to be part of this conversation. I did previously work at CMS. I was an economist at the Office of the Actuary at CMS, and that was a really great experience because I actually got to work on the team back in 2016, 2017 that puts together these national health expenditure projections. So I actually know quite a bit in terms of the methodology that the actuaries and the economists use to forecast these national health expenditures over time. Up on this slide, we've actually pulled in the most current NHE projections from the CMS Office of the Actuary. And by 2031, we're looking at health expenditures to be just a little bit over $7 trillion. And currently for 2022, health expenditures exceeds $4 trillion. And as you can see from this chart, health spending is going up. A very big driver of that is that health expenditures are strongly correlated with economic growth. As the economy grows, people spend more on health expenditures. So an even better chart to look at is this next one, which compares health expenditures to GDP. And what we see here is that health expenditures are growing over time, or expected to grow over time as a percentage of gross domestic product. It's inching closer and closer to 20%. If you ever go back and read the prior NHE projections that have been published in past iterations, CMS has always projected that at the end of the 10-year window, we're going to be really close to 20%, and that really hasn't changed. The most current projections are that health expenditures will get close to 20% by the end of that 10-year window. But
it is kind of fascinating when you go read those kind of NHE reports, and that there's a couple of points that you draw to on these charts. I mean, one thing that you and I have talked about that's always interesting is that we go through periods, particularly with kind of, let's call it technology breakthrough. It could be a wave of new pharmaceutical treatments. It could be, another breakthrough in terms of treatment technology. So, different, like say, radiation oncology modalities or imaging. And you'll notice in the chart that healthcare is lumpy. Like even though total spending, goes up with kind of population and other things, like you'll notice that you'll have an increase and then a plateau, and even it'll start to come under control. And then if you have another increase, it's usually going to be driven by some kind of breakthrough technology that gets adopted. So I would throw you back to your kind of comment about looking at that projection, that obviously you see this big spike with COVID, which I think we all know what happened. We spent a lot during COVID. But, come back to present, now in that 22, 23 zone, they really just they're straight lining it out. But I think we know that everything that happened pre-2020 is kind of indicative of how this curve runs. Like, things plateau and then they kind of rise up and then they plateau again.
Yeah, that's true. I mean, if you look at that historical health expenditure kind of in terms of that pathway that it's been going, health expending does rise when the economy goes up, and then when the economy goes down, it does have an impact on health expenditures. So since GDP growth does zigzag, you typically see health expenditures having a similar kind of structure over time. In terms of projecting health expenditures into the future, it's very, very difficult to project changes in gross domestic product. It's very difficult to project what's going to happen in the economy. So oftentimes what happens with these NHE projections is that in these later years of that 10-year window, they tend to just project that there's going to be consistent economic growth during the latter period of that phase. And because of that, we see this kind of smooth growth in national health expenditures.
Linear.
Right.
Very linear. So I guess our last thought on this before we kind of dive into it more deeply is just, we've been for a while always saying that healthcare spending is threatening to breach that 20% of GDP, but it never quite gets there, even on projections. So, even now you look at the last NHE projection, and they actually show what healthcare percentage of GDP was about 18.5 right now.
Right. About 18.25.
You look at where they are at 2030 and it's still under 20. So obviously it's a projection, so can't hold them to 10 years in the future, but it is interesting to see that, sort of people are showing the curve starting to flatten out a little bit. Let's kind of break it down a little further. I think what's really fascinating is kind of when we look at how the sort of expensive elements of healthcare have broken down over the last few years.
Yeah, in terms of the most recent national health expenditure accounts, in terms of total spending by different category, we do see that hospital care is responsible for 1.3 trillion of those national health expenditures, followed by physician and clinical services for 865 billion, and then $378 billion for prescription drugs. So those are the top three categories in terms of overall spending by category within the national health expenditure accounts.
This is a very interesting, when we put this stuff together, over the last few years, what I find really, really interesting is what's changed. So if you go back 10 years, you're going to find that hospitals were number one, as they are now, but prescription drugs were the second largest category, and that has now been eclipsed by the growth of physician services. And obviously that accounts for the fact that these physician services actually were once lumped into the hospital category. So, but it's just kind of fascinating in the total service volume. Obviously we've been having for various reasons, we've been having a discussion about prescription drugs in Washington, and in some ways we're still having a conversation about prescription drugs. We have had, since 2015, but it's often true to what I say about Washington, and that it seems like they're fighting the last war. They're always having a debate over some, issue that has been resolved at state, local, or market level quite a bit before they get to it. And here we are again. Prescription drugs actually are not anywhere close to being the major driver of healthcare spending, but we're talking about it.
Right. And prescription drugs is one of those things where we often tend to focus on the blockbuster drugs that have recently been released or are likely to be in the pipeline in the next few years. But one of the things that we've seen in the last 10, 15 years with prescription drugs is that there has been pretty meaningful growth in the generic dispensing rates. And as generic drugs become more commonly used, this lowers the overall average cost of per prescription drug. So
that's true. And then you have like the Part D program in Medicare is I think about 80, somewhere in the 80s, 80 to 85% generic converted.
Right.
So, I've noted that with clients in the past that when the prescription drug debate first started, back in 2015, it actually was started by the insurers who were talking to lawmakers in the Hill about the fact that the generic price inflation had increased so much. You also had some novel things like Hep C drugs that launched that were very expensive and in the spotlight. But what the insurers were concerned about, which kind of started this whole conversation, was that per capita spending on generics had gone up very significantly because of generic consolidation, and they were concerned, justifiably so, that eventually, in a program that was so dependent on generics, that eventually the premiums were going to increase, which they hadn't done pretty much for the entire program. From your end, Devin, what can you say about kind of hospital spending?
Good question. So as you mentioned, hospital and physician spending did take a hit during the pandemic, but we are seeing that volumes are returning to more current pre-pandemic levels. For hospitals specifically, I know one big concern is rising labor costs that these hospitals have to deal with.
All right, let's move on. Let's do a quick look at kind of major sources of funds. Again, this is 21 data. We're kind of going off of what they use in kind of the NHE report and some other reports. These are pretty common things that have been fairly consistent. Obviously private health insurance continues to be, your number one driver in this country. And, followed on its heels following is Medicare. Medicare is obviously continuing to grow as you have more and more boomers coming into the system. But, on the last side, I think we did notice that, we've noted obviously that hospital pricing for the commercial segment is higher than they get paid for Medicare, and also quite a bit higher than what they get paid for Medicaid. So I don't know if you have a different opinion on this, Devin, but one thing I've always observed is that, Medicare, even if the population of Medicare is growing, the total spending still tends to undertrack commercial, just because, particularly when it comes to hospital spending, your commercial pricing across the board is often higher.
Yeah, that's true. That's something I also researched when I was at CMS Office of the Actuary. Hospital prices are higher on the commercial side than they are in Medicare or Medicaid. One concern that the trustees have in their annual report is that they're not entirely sure if that discrepancy in prices is able to kind of hold up over time. There is an open question as to whether or not having such slow growth in Medicare prices, if that's sustainable in terms of preserving access to hospitals.
Let's go to our next slide. We're going to kind of dive into Medicare itself. Again, we see very similar to the overall national track. I mean, obviously, hospital spending is the bulk of Medicare spending. But just as we saw nationally, physician and clinical services, which includes, things done in ambulatory surgery centers, is now a sizable wedge that has grown to the point where it has eclipsed pharma spending. Prescription drug spending is generally going to encompass both, the Part D prescription drug program and then Part B drugs, which are also administered within kind of the physician services wedge. But, Medicare will account for those separately. So, I mean, that's really, Devin, I don't know what you think. That's the most fascinating thing, again, just watching kind of the growth of physician services across the board, but also in the Medicare program. It brings us to an important couple of observations. We've had a couple of trust fund warnings. We're going to get another one this year. COVID basically gave the trust fund a couple of extra years of life. The total spend out during the pandemic from Medicare side actually, underperformed their projections. Now, however, that we head into 2025, we're kind of right back at it. And we're down at are we down at 6 years now?
6 years in terms of, the Part A trust fund should expire in 2031. So I guess that would be about 7 years.
Yeah, and in practical terms in DC, I mean, one thing I will note is that in my time here, we have done two major exercises in fixing the trust fund. One was, kind of in the 1995 to 1997 period and culminated in the Balanced Budget Act of 97, which was it did many things, but primarily what it did was it was essentially a major repricing in Medicare to extend the life of the trust fund. That bought it quite a bit of time. They didn't have to come back and address it again until 2009 and 10 when they enacted the Affordable Care Act. So here we are again, heading into 2025. It seems like this always tends to happen in an odd numbered year right after a major presidential election for obvious reasons. It's a lot, if you're going to do an exercise where you're going to try to reach for some bipartisanship and fix the trust fund, your kind of safest window to do it is, right after a presidential election. One thing that I will note, the best way to think about a fix the trust fund exercise is that one, everybody has to be in the fire. So, that would include these days hospitals and Medicare Advantage. Hard to put ASCs are one thing, but it's hard to put physicians in the bucket of savings right now because the way that they usually fix the trust fund is they effectively lower everybody's growth rate, usually a couple years, maybe 3. If they do multi-years, they tend to do just incremental growth reductions. If they're going to do something big, like a point to a point and a half or more, it tends to be maybe a couple of years on the sort of front end of your 10-year window. But, if you want big money to save the trust fund, you got to have hospitals in it. And these days, you're going to have to put some growth restraints on Medicare Advantage as well.
Right. It's the hospital insurance trust fund that is the issue. And Hospital spending is the biggest category for it. Initiatives to reduce spending for physician services isn't going to help the hospital insurance trust fund because it just goes into the Part B trust fund.
It's also true. Also, but the physicians also have no growth rate right now. So what growth rate are you lowering? Under
Right.
macro, their growth rate is 0. So this is the one time the docs, this is actually a political opportunity for the physicians to try to get a new growth rate. One thing about these bills is that the amount of money that's on the table in 10-year savings is so big that some people can actually go for something that's not entirely negative. It's in many cases positive.
Right. One of the things we've been seeing on the hospital side in the Medicare program is that volumes are returning to pre-pandemic levels. And we're also seeing an increase in the intensity of care in terms of the services that these patients are receiving. It's also worth noting that over time, more beneficiaries are moving into the Medicare Advantage program. And this has an impact on fee-for-service spending in terms of as more beneficiaries have gone into the Medicare Advantage program. This has led to lower per capita spend for Medicare fee-for-service beneficiaries. A big part of this is that many more dual eligibles are moving into Medicare Advantage, and as more dual eligibles move into Medicare Advantage, it lowers the per capita spending for those remaining Medicare fee-for-service beneficiaries. So in terms of current projections for Medicare expenditures, the trustees report is projecting 4.8% growth for Medicare expenditures in 2022. 8% in 2023, and then 7.8% annual growth 2025 to 2031. In terms of driving this growth, hospital spending is the principal driver with 8% growth in 2023 compared to 4.8% growth in 2022. And that's mainly driven by just an increase in volume from the pandemic and increases in the intensity of care.
An important point in all of this is to talk about the Medicare Advantage program. So if you go back and look at the 21 data, which we didn't put this up, but you look at the 21 data, MA has not overtaken fee-for-service in terms of total enrollment. But if you fast forward to the present, it has. So now this year, it's about 52% of beneficiaries. Is that right?
I believe so.
Yeah, so now MA is 1 out of every 2. I just saw as part of the projection release, they were saying, it's growing at a steady clip, but it does take a while for it to kind of meet a big new milestone. So they're kind of projecting that it won't hit 60% until like 2030, early 2030. But it is interesting. You mentioned that a lot of duals are kind of part of the growth in this program. But another thing the trustees have noted is that MA has actually it's starting to lower the overall per capita spend on fee-for-service, yeah?
That's correct.
MA is in a weird period that we've talked about, and that part of this is pandemic related. I will go back and argue that part of this is definitely due to the overall kind of discombobulated spike that happened in the pandemic. But Medicare Advantage right now had been roughly at parity with fee-for-service in terms of payments to the program per beneficiary. But and with those payments, you're actually getting more benefits because MA tends to offer additional supplemental benefits versus fee-for-service. But MedPAC kind of tracks that payments versus beneficiary and fee-for-service number, and it had drifted during those pandemic years. It looks like it's risen up to like 105, 106% of fee-for-service. How that affects the future of the program, though, is you've kind of seen it's come back around. Like right now, MA is in a period where if you look at kind of backward-looking corrections to the rate update that they do every year, the rates are kind of going to be flat. They're like flat for next year, and they'll probably be, pretty low to flat for the year after that. So I guess bottom line, Devin, is MA is not going to be out there racing anybody, allowing people to raise prices on them, I think, very heavily.
That's a great point. It makes a lot of sense.
And what you kind of charted out what I thought were some other interesting points on other things that have basically had the effect of reducing fee-for-service per capita spending that you pulled out of the recent trustees report.
That's a great question. And in terms of other things that were outlined in the Medicare trustees report that have been helping to reduce Medicare fee-for-service spending, one, the Medicare beneficiaries that have survived COVID-19 tend to be healthier and have lower expenditures. And then secondly, on the hospital side, there has been a shift in terms of major joint procedures moving from the inpatient setting to the outpatient setting. As many will remember, like 5-6 years ago, major joint replacement was one of the most popular MSDRGs, or Medicare Severity Diagnosis Related Groups, within the Medicare program. And that's not the case anymore. Many of those procedures have moved into the outpatient setting.
That's right. All right, we've covered some excellent top line points. One thing that I always enjoy talking to you about is, as somebody who, was part of OACT and part of that crew that models out health expenditures, when we think about 10-year projections, it's always helpful to kind of add that cautionary note in terms of how accurate is modeling out to the future and what are some of its, trade-offs and limitations. So let's talk about that for a little bit.
That's a great question. One of the things that OACT typically does after every projection is to actually go back retroactively and compare the accuracy of their model in terms of their past projections. And one of the limitations with putting together these projections is that it's very difficult to predict what's going to happen within the economy, which is it is the biggest driver for these national health expenditures. The other limiting factor is that these projections typically follow current law. It's based on whatever laws are currently within the baseline, and it's not within their purview to try and estimate changes in legislation or regulatory changes that could happen over the next 10 years. Because of that, these projections tend to be very accurate within the first couple of years, but once you start looking out into that 10-year window, there are different things that can happen within the economy. There can be different technological changes. There could be new blockbuster drugs. There could also be changes in legislation, and all of those things can very easily change what you would see 10 years from now.
Now we know that. My first taste of that was at post BBA 97. A couple things happened. One was that the federal budget went into surplus in the late 90s. So a couple years after BBA 97, the government was no longer in deficit. It was actually sitting on a surplus. At the same time, though, you did have hospital consolidation occurring, which people had projected as part of the bill. But of course, now the economy's in surplus. You better bet the hospital advocates were up there screaming bloody murder about hospitals that were closing. And then on top of that, you also had something that the law didn't really intend, but CMS definitely made kind of their most infamous mistake in implementing the law. And that, when they designed the original skilled nursing facility prospective payment system, they did not account for all of the costs that go into SNF care and the PPS design. And on its opening year in 99, basically every major nursing home chain that was carrying debt had to restructure because the reimbursement shock was so severe. So bottom line is Congress then in two different pieces of legislation had to jump in and inject more money back into the system. And we see that every couple of years we'll have kind of micro correcting Medicare bills. Sometimes we have one every single year just to kind of fix, dock cliffs and other things, but you definitely kind of have one every couple of years that will tweak all of these things. One thing we should talk about, Devin, is that, if you look back in the last 10 years, if you look at CMS, OACT, the Office of the Actuary, or you look at, CBO, the Congressional Budget Office, a lot of their projections have actually overestimated spending. So, I know we've kind of mapped out a couple of reasons for that, but why don't we dive into that breakout?
Yeah, so in terms of the prior 10 years, one source of overestimates has been there have been fewer blockbuster drugs than anticipated. It's very hard to predict in terms of what type of drugs are in the pipeline in terms of when they'll come to market. And historically, CBO and OACT have kind of overestimated the impact of blockbuster drugs. The other issue has been the generic dispensing rate, which we talked about previously. Basically, the generic dispensing rate has risen faster than previously expected, which helped to bring down the average cost of a prescription drug in the Medicare program. And then other things that have impacted Medicare spending in the last couple of years that haven't been modeled or forecasted was that there's just been better management of cardiovascular conditions and better use of medications to control risk factors for hypertension and diabetes. And this improvement in care has led to, or has helped to slow down the growth in Medicare spending for hospitals and physicians.
Yeah, another development was also in Medicaid, right? And on the long-term care side.
Yeah, that's a great point. In terms of what the CBO has found in terms of their evaluation of their prior numbers is that there has been less than anticipated spending for long-term services and support within the Medicaid program. This has been due to states shifting Medicaid patients from institutional to non-institutional settings, as well as managed care plans better managing these patient populations in the Medicaid program.
No, that's right. And I mean, that's also something that I think kind of crept up on the sort of Washington analytical community was, the sort of rapidity with which states, moved either full tilt managed care for Medicaid or, moved in kind of really high 80 to 90% of people in that program. So in Medicaid, it's kind of a managed care world.
Very true.
Well, that's a great opening episode. We don't want to take you too long on this. We're probably going to come back about once every quarter and dive into interesting things in the data because, on our end, we often find that the data tells very interesting stories that often are counterintuitive to a lot of the Washington narrative, which those of us who in DC know is often influenced by various advocacy groups. And the actuarial reports are often, just a straight up look back at what's actually happened. And then we'll be talking about, where we think their projections are probably spot on or where they're maybe a little off. But lots to talk about. It's always great to have you along, Devin, because, your data team does such great work. And obviously we have a lovely near-term window into what's happening. So thank you.
Thank you for having me.
And thanks everybody for joining us. We're always excited to do these, and we will be back at you very, very soon.
This material is for general information purposes only and should not be construed as legal advice or any other advice on any specific facts or circumstances. No one should act or refrain from acting based upon any information herein without seeking professional legal advice. McDermott, Will & Emery makes no warranties, representations, or claims of any kind concerning the content herein. McDermott and the contributing presenters or authors expressly disclaim all liability to any person in respect of consequences of anything done or not done in reliance upon the use of contents included herein. Copyright 2022 McDermott, Will & Emery. All rights reserved. Any use of these materials, including reproduction, modification, distribution, or republication, without the prior written consent of McDermott is strictly prohibited. This may be considered attorney advertising. Prior results do not guarantee a similar outcome.